Delivering quality health care may be the single greatest challenge facing our country. It is the classic rock and hard place conundrum. On the one hand, there is the desperate need to cut costs, while on the other hand, spending money on good primary care today will save millions down the road. In North Carolina, they have created a community-based healthcare system for Medicaid patients that may be a model for the rest of the nation. The system is built around 14 regional healthcare networks in which 3,000 local physicians are linked with high-risk patients. Medical interventions are made, and chronic diseases like asthma and diabetes are addressed. Community-based case managers are hired locally by the networks. They work closely with patients to ensure that they are getting the care they need to prevent costly complications. The result is that Community Care of North Carolina has dramatically improved the health of thousands of patients while saving millions of dollars. What's the secret? It has a lot to do with putting care back in the hands of family physicians.
The whole program is about relationships. And the thing we wanted to do really is twofold. One is to save dollars so we could provide more care with the same dollars. And secondly, in this particular program, they have an assigned doctor, they have a medical home, they have care coordinators who talk to them, and their mentors and their chaperones and their best friends and people that a patient feels comfortable calling and asking questions.
Life's a child, it's just a child that's so crying. Let your love cover me like a pair of angel wings. You are my family.
Community Care of North Carolina started in 1998. There was an interest on the part of the folks at the Office of Rural Health to bring care to the local level because there was a belief that primary care physicians could manage some of the more significant chronic illnesses much better at the local level with local resources.
I think as a practicing physician, particularly a family physician in a rural area, you have the opportunity to see how all the different parts of the healthcare system fit together.
I've known for quite a while that access to care can make a huge difference, particularly for children, in preventing hospitalizations and preventing significant loss of time at school around certain chronic conditions that are common in children, such as asthma, diabetes.
We came to the realization the best way to manage and improve the care delivered and to save money is to have a clinical model, which is to figure out how better to take care of patients in the local community.
So one of the processes was for us to pilot a variety of ways of doing this and discover what seemed to work best for families, what worked best for providers in practice, and then we replicated it across the state.
Over the last 7 or 8 years, it's grown into a statewide program with 14 networks throughout the state that cares for 750,000 of our citizens who are on Medicaid.
The folks that are involved in the practices in all of these networks around the state, I think, have a common characteristic of wanting to be able to really offer well-coordinated, collaborative type care for their families.
Community care is able to provide resources and support and tools for our practice to make it easier for physicians in our practice to follow best practice guidelines as we are trying to help children, especially those dealing with chronic diseases.
It's extremely important when we're trying to look at our diabetic patients across the state that we make sure they have nutritional counseling, prevention, take their medications, have the resources needed to prevent those long-term complications.
For instance, for diabetes, we really try hard in trying to identify overweight children, put into place dietary and exercise interventions to prevent worsening of obesity and hopefully then prevent the development of diabetes.
How's your sugar been running?
High. Probably about 230.
Okay.
Sometimes I have to remind her that we have to exercise, but I can't push her into doing something.
I've learned to about the diet and the exercise. So we try to walk, we try to eat healthy. I try to get my whole family involved, and I don't want my daughter to get it, get diabetes.
I don't understand all of it, but I do get most of it. And it helps me to learn and understand that I need to take care of myself.
For asthma, we try to do a really good job of detecting and identifying asthma as early as possible, and then putting into place again those best practices.
And so the dry powder can come out. You want to hold this like a hamburger, not down and not up, but straight like a hamburger, and suck on it like a milkshake. And that's how you'll take your medicine every day. When I first met Nubia, she'd been in the emergency room 5 times, and so our goal is to have her stay healthy and to have her breathe well and to keep her out of the emergency room and still be able to participate in life activities that her friends and that other girls her age are participating in.
Also, if we are struggling with the patient and the physician having a hard time trying to manage that patient, then we can refer to our case manager, who then is able to follow up with that patient and really work intensely with that patient one-on-one. Be able to do a lot more education, a lot of self-help skills, able to go to the home and do extra help if they need, and also are able to link those families with community resources.
As a case manager in the community, we have a unique view of the counties that we're in, so we know what's out there and what's available to Nubia and to her family. So in Nubia's case, we were able to link with environmental services and have them come out to her house and perform an environmental survey and try to find out what triggers may be causing Nubia to not breathe well every single day.
Gave me some allergy pads to put over her bed and her pillowcase and to get the dust off the ceiling fan. And just showed me a lot of things like stuffed animals in her room that can trigger her asthma, so I think it was really great.
We were very gratified that in the first year of using a quality improvement protocol for asthma, that we reduced hospitalizations for children with asthma by 17% in this county. And we reduced the amount of time that they spent in the emergency room. But even better, we had a significant decrease in the number of absences from school.
For the families, particularly those families on Medicaid, having someone to be a partner with the physician to help the patients through the system and making sure they get what they need is invaluable.
As her case manager, we're concerned about Nubia's entire life, so not only her physical care, which would be asthma, it may be things she's dealing with as an adolescent, but also social issues, maybe issues the families have, and sometimes we deal with housing issues, food issues, just pretty much anything the family would need that we feel like we can help with as liaisons in the community.
Well, Mary Hansen has helped me out so much as far as trying to get things started for Jasmine, making sure she does a good job with taking care of herself. She's starting middle school this year, and I'm really excited about her going to this diabetes camp, which I wouldn't have been able to afford on my own without the help of Mary, my daughter. If you could have just seen the look in her eyes whenever she went to this camp, it was amazing.
Come on in.
But our case managers take care of them as a family, and whatever they need is done, not just the disease management. If they need help with transportation, housing, other medical needs, our case managers are there for the patients and their families.
Jasmine is actually my patient. I'm her case manager, a nurse case manager. The American Diabetes Association was going to have a camp, and so when I called Kenyon and said, have you thought about camp? And she said, I had actually, but we were looking into the camps and we just can't afford them. And I said, well, I think if we could get some donations, some scholarships, we work some things out, we might be able to send Jasmine.
Well, our case managers are patient advocates, and so it's not another middle manager. They actually facilitate making sure patients get the best care.
Connecting all those dots, you did it, and she got to camp.
My hopes are that she will start to take a more active role in her treatments, her medication, just the entire thing, and actually start to pay attention to the way she needs to take care of herself.
So we're hoping that with our case management, we can provide some guidance, avenues to medications and treatments, and physicians and all the things necessary to keep them healthy now.
The success of the Community Care Network program is really that we have focused on establishing access for folks so that they have a medical home. We've agreed on standards of care, and we've helped develop systems for folks so that they can meet those standards of care. In addition, we've drawn in the other partners in the community who can assist with offering assistance to families.
What do you do for a living? I'm a country doctor. At heart, I'm a family physician who's committed to a town of 1,000 people.
When you take care of families, you realize all of the other things that they carry every time they come into the office. And so seeing children one at a time in your practice is incredibly rewarding and incredibly important. But it became obvious that there needed to be systems changes at the practice level, at the local community level, at the state level.
Making my regular trip from my home in Mount Pleasant to Raleigh, the state capital, where I serve as Assistant Secretary for Health Policy and Medical Assistance, and also State Medicaid Director.
And it's been very exciting to participate in a program that has made this huge difference, and that has allowed me to participate in changing policy for children that affects, in turn, the individual child that I might see on a given day.
Well, rather than in trying to cut services, take people off the rolls, cut physician and provider fees, we concentrated on making sure that people weren't going to the emergency room when they didn't need to, avoiding hospitalizations, better prescribing habits. Rather than limiting drugs, we made sure people got the right drugs.
And we began to compute what does that mean in real dollars. But the truth is, in the last 5 years, Community Care of North Carolina has saved the state $100 million every single year for 5 years running.
We have shown by measuring quality, tracking outcomes, that our Medicaid recipients are receiving better asthma care, better diabetes care, and we're saving hundreds of millions of dollars on the expenditures on the Medicaid program without costly regulation.
The ability to do quality improvement and really show that this makes a difference and to raise the standard of care in a community is very exciting, and has been what's really held all of the primary care physicians in this project and allowed it to expand around the state to include many, many more practices and physicians.
Driving in from Mount Pleasant, my small town where I live, is pretty symbolic of what's successful about this program.
The innovation and the answers are not coming from here in Raleigh. They're coming from engaging the people who actually do the work, who actually live in the communities, and saying, how can we help you do a better job?
Well, it's a calling for me. Public health is my heart and soul, and so I just can't imagine a better job, that I truly, every day, get to go and try to make the system better for physicians and for families and for patients, and by doing so, it saves everybody money. So it's just doing the right thing for patients that aren't always the right thing isn't always done for those patients.
Waves a snatch of hay in a common born. In a lonely house of Adam's fall lies a child. It's just a child. There's soul crying. Let your love cover me like a